Now in wound healing, that's been one of my great interests for a long time. The wound vascularization is critical, and especially in those that are like pressure sores or decubiti or that kind of things, where they're an avascular ischemic area, they don't have blood supply, and I defy you to be able to get them closed consistently. And if they're very large, it's almost impossible. You can't graft over the top of an avascular bed. Everybody knows that we're looking for granulation tissue. If you don't have it, you don't get it, and you're not going to get the graft to take either. So by getting angiogenesis as being one of the strong points, so it's controlling inflammation, mediating it to some extent, and it is allowing new growth of vessels into those things. It will get the result that they're looking for. I'm going to just talk about debridement for a second. Is that those of you who take care of wounds understand that if you don't do a good surgical debridement, and I don't mean scratching it, I mean you're going to have to get the margins to flatten, because the wound doesn't heal from the center. The wound heals from the margins. And if you have the margins that are evernated and rolled over, that's a wound that is stalled, and that's going to fail. So you're going to have to cut that off. Sometimes the first time you do that, the patients will blink, and they had a wound. Now you've made it a centimeter bigger all the way around, and they're saying, "Holy cow, what did you? I have this hole. Why are you making it bigger?" So prepare them for that, and understand that if you don't do it, and if you don't do good debridement every time, you're going to be slower in the wound healing process, and it's pretty simple. This is an example we used. This is a cardiovascular patient who had a breakdown in the inner thigh, and it was wet, secreting, oozing stuff. They immediately want that to be gone. They wait for about 2 or 3 days, and when they realize that thing's not going to grow closed by itself. If you'll notice in that picture in the upper left, see that on about 10 o'clock to 11 o'clock, see that rolled edge? See how it's humped up? That's eburnation. That's when you know the wound is stalling there. That this has been sitting long enough that this wound is not closing. All you do is you read the margins. We use, in this particular case, we use biocellular. We put biocellular underneath the trauma site, and we put it along the margins. This is something that's nice because you got a soft tissue depth that you can do that. When you get into bone exposed sites, you don't get that luxury. So you see the bed of granulating bed now. You can see the white lines and the pink junction. That's the new cells going out. The cells mobilize, you remember, they get moving and they grow it out over the opening. Then in the bottom slide, we just let that go because we wanted to show them. But what happens is all these wounds will begin to contract at a certain period of time, 4 to 6 weeks. And so that was contracting and closing by itself. And we only had to treat this with, I think, two injections of the biocellular underneath and then let it grow close. So that was better than doing some of the other alternatives. The heel pressure source, it's an old woman and cardiovascular disease and hypertensive, and she's been laying in bed, so she's got a heel compression. You see the necrotic tissue, everybody knows that's got to go. You see the white of the bridge across there, that's got to go because that's dead tissue, didn't have any vascular supply, right? And so you clean that out, made the debridement. We don't change the dressings as frequently because we want granulation tissue to be stimulated. So between the time when you do the debridement and you at first activated PRP, it's going to be sprayed on, and it's going to be sprayed on with thrombin, autologous thrombin, or it's going to be human recombinant. And then you begin to see granulation form. So you give it the wound time because the growth factors are going to be in that mix, and that where we would normally say, well, we want to see it every other day or something like that. You don't do that with this because these cells will stimulate, and you'll be shocked when at about the 4th day and you take it off and you don't know whether you're going to get a giant pocket of material that oozes out of it or you're going to get something. What happens is it begins to cover over the bone. That's bone that's in the center of that top right picture. So that's at about 2 weeks, so that you can't put anything under these. But you can debride the margins and you can inject around the edges, which is what are you trying to stimulate? We decided maybe that the wounds heal from the outside towards the center, right? So we got to that point at 2 weeks. We're a long ways from finished. However, then where you see it on the bottom left, when you're out and around 8 weeks now, this is a wound now that has completely granulated, and probably in the old days, we would have grafted this point and got out. However, grafting is not always guaranteed. It creates another wound, which in an 84-year-old hypertensive, you don't need other wounds if you don't have to have them. So instead of that, if you'll just maintain, you can continue the debridement, keeping sure that the margins aren't beginning to roll to that eburnation, and that if you just wait enough time at 18 weeks, that entire wound completely closed with an advantage that it didn't have before. It's got a vascular supply underneath it, and it doesn't tend to recur as easy. And this tissue is going to be softer because it's going to be more vascular. So this is just the same example, only this is a terrible ankle coming out diabetic. The same process there, but if you don't make that wound to the full size, that defect is greater than the opening. So that's bone you see okay, but if you don't realize that about the edge of the red down below that on the foot, that was still part of the dead tissue. And with doing the same process, we always try to take it to say, well, how far can this wound go? The important thing is there is not that this one closed, but I will tell you that it's hard to keep diabetic ulcers, for example, ankle ulcers, to stay closed. Because as soon as they don't wear their compression garments, they don't do anything as far as salt intake control or fluid residual, or almost all of them that have diabetes have lower extremity edema anyway. If you don't stop that, they'll recur. So if you want an annuity where you, about every maybe 3 months to a year, you're going to do another ulcer because they're going to break down because they are not vascularized. These people, when they revascularize, they will resist recurrence. So they can have bouts where they don't wear their garments, they do swell, they eat too much salt or whatever retaining fluid that they got going. They'll still resist coming back. This is one that had been present for a long time. I don't know why they waited so long, but he had, I don't know, a dozen different events all occurring in the same ankle, same location. And if you get it to heal at one time and get it soft and vascularized, you're going to have it, it's going to work for good. The aesthetic surgery aspects of it, we're talking about solar damage in this case. On the pre-op picture, it's very difficult to see in photographs, but if you'll take a look at the stippled appearance of the skin, it has a texture that is bumpy, lumpy, fibrous tissue changes, pigment changes, in many cases solar damage, for example. What's happening in the course of this is simple grafting of the subdermal fat into doing the cheeks. Many people do it different ways, and there's probably not a right or wrong way, whatever works for you. But you'll notice that at 1 year, look at the texture change of that skin. We didn't do anything, no lasers, there's no chemical peels, there's nothing been done to that except what was done under the skin. The problem we have with estheticians nowadays, where they're doing the roller punctures and spraying the skin with PRP, then they roll it in like it's going to go in. They're stimulating the dermis if they go deep enough there, so they're going to get a dermal reaction, but it's not going to be because of the PRP. They just wasted the patient's money in order to do that. If they're going to be good enough, there's a company in Canada that's in the process of developing an injector gun, which is like a tattoo gun, has, I don't remember, 6 or 9 needles, but it's got pores in it. These are needles, not just little stab wounds, but they can inject into the dermis. If you hit it into the dermis and you can do PRP into the dermis, you got a different animal. So the lower dermis is going to have a little bit of blood supply, but the subdermal plexus is keeping it all alive. So, not complaining about that. But we use this in facelift changes, and primarily for the middle third, we've always been having stuck to you can't take a flat patient's skin and make the thing look good by pulling it even flatter. So by volumization, augmentation, it's become a standard part of most plastic surgical practices that you're going to augment the middle third of the face because that's going to be a weak spot in your lift. And this is just an example of postpartum, 2 babies. You can see the sagging, one breast was favored in the nursing, obviously, so you can customize your implant here. This is straight the post-op back graft with PRP, and we did about 325 cc's on the right and 350 or 55 on the left. And at 2 years, it still retains its function. You can see where the fat was taken on the lower abdominal wall. The pluses for me were meaning that's the part of the most prominent degree of fat. And so that's were the sites that I took that for the donation. Now, we'll go getting to the end of this slide. You guys have been really good about staying awake. Understanding that the cellular SVF has a function, it's fairly highly regulated, really used in IRB and research studies mostly, with the exception of the cell enrichment that we talked about. So if you do that, you're going to have to justify why the cell enrichment can work. Now, many countries don't have a problem with that, so when you see the papers coming out of Brazil and all these other places, they have no restrictions on doing that. Europe a little bit different, and we're even more different than them, and the most strict is probably comes out of things like Korea. And Japanese FDA is quite significantly in control. The deployment in this thing means that you're going to have to use the enzyme. We talked about collagenase. Well, we have ability now to prove that we are not introducing exogenous collagenase by the use of this Liberase TM, because if you'll add to, in the process, in the protocol, you'll add 2 cc's of platelet for plasma, that will bind all of the collagenase with a thing that, as you recognize, that the alpha macroglobulins that's in the plasma, that's going to bind all the thing. We tested it through Harvard, and they could not get it to register any ever. So in that sense, we have the protection of knowing that we're not introducing exogenous collagenase, and knowing that everybody has collagenase in their system. So I'm not going to go on to anything except just kind of give you the overview. I think this is coming. I think this FDA, if they can ever make up their mind, will finally realize that they can do something without it going to hurt the patients, because FDA is only really worried about 2 things. Number 1 is safety. The safety profile is pretty prevalent because there's been a lot of clinical trials using cellular SVF. So the safety factor is really excellent. I mean, out of the several, probably 200 or so of the cellular SVF deployments that we've done, we've not had a reportable adverse event or severe adverse event on any case. If you're using autologous tissue, and if you take care of it and you do the proper separation and isolation, you're going to be able to be okay there. Whether you develop it and put it in IV or IA depends on what your purpose is. If you're trying to get to the pancreas or the kidney or the liver, you're going to go arterial, or the heart, arterial. If you're going to go to the lungs and you want it to circulate, then IV is perfectly acceptable. All those other techniques are just other locations. And as I pointed out yesterday, probably the most important slide here is you want to look to the future. Don't keep looking backwards and assuming that that's going to be the way it should be, because there are things that will come up and bite you sometimes. So do good thinking about that. And thank you for your attention. I'm sorry about the length of time. Any questions or after?
So what I'm gathering is that from your discussion is you have centrifuge fat, microfat, and nanofat, right? Basically.
No, centrifuge fat is a separate thing. The gradient separation
in other words,
is tissue SVF. Yeah.
So for facial volumization, I wouldn't micronize it, or I would nano it.
No, probably wouldn't have to.
Right.
Except in certain locations, like we talked about the lids.
Right. So my question is that I had some thoughts of maybe treating wounds from small openings from breast lifts, breast reductions, and small openings. Yeah. So which one of those 3 are you using topically? The micronized?
Topically, I'll use the tissue SVF, and I don't need to emulsify it.
So just the way it comes?
Yeah. But the advantage of emulsification, like in the foot or in the tight tissues where you have bone right underneath it, if you use the emulsified fat, it's easier to inject because you can get a smaller needle in there and still get a plane for deposit. So if you're doing the thigh, you've got this kind of shot.
So was there topical application and injection?
Yes, we topically applied spray. We topically applied the autologous, the PRP activated when we place it onto the wound, and that's fat. And then we also go in the margins underneath with biocellular.
And you're injecting what at the margins? I'm sorry.
I'm sorry?
What are you injecting at the margins?
At the margin, we're doing straight biocells, just the same process of tissue SVF, small.
Not micro and not nano?
Doesn't have to be. The micro and nano is a little easier. Again, remember that if you put in too much into the margin, you're going to kind of impede the vascular stuff that's trying to grow. So you don't want to get heroic and try and do too much volumes in there. You want to make sure your distribution is even and consistent.
So if you were doing that, which one would you use?
I would normally use at least, I'd go through the emulsified, partially emulsified is what we use.
I'll call it micro?
Call it micro, that's the
Well,
trouble
I
is
just
there's
see
about
three
10 or 12 of those, but yeah, that's right.
Well, I'm saying there's 3 levels.
Well, you've done it, the 30 passes through 2.4, 1.4, and
Okay,
1.6.
use that to inject. And how about topically?
And you can use that same thing, or you don't even have to go down to the micronization.
Okay.
You can use straight
All right.
tissue SVF on top.
I got it.
It's amazingly calming to the wound, to the site. It will help quiet the site. Help.
What kind of dressing do you put over the top, up top? Like, do you
Over the
secure
top
it?
of what? Say again?
What kind of dressing do you put over it if you use it as a topical graft? I
Okay,
suppose, over,
you're gonna have to use a permeable membrane because you want the stuff, the fluids to come out, but the contact of the growth factor stay in. And so you'd use a semi-permeable membrane. What we used to use quite a bit is still available. It's a xenograft using porcine skin that's perforated. You can use perforated skin, human,
Sure.
Anything that
But
will
synthetic,
allow
like a
some of the
Mepatil
fluid
or
to come
something
out.
like that.
It's a what?
like a Mepatil or Vaseline gauze?
Probably wouldn't use Vaseline gauze right at first because you want the fluid to come out, but you want the contact of the thing. And Vaseline gauze will slow the development of the growth factor. There's still that you can use some adaptic kind of thing.
Adapt, okay,
Yeah.
same thing.
You can use adaptic, but just be prepared that it's going to take you probably a week longer. Still get the same result because it lets the fluid out, holds the wound moist, and a moist wound will heal faster than a dry one. And so those of you doing plastics here, you're going to understand that most of the family doctors want to let the thing just dry out and blow away.
Like
In
that
fact,
groin wound, or say you had a decubitus ulcer and you laid some fat in there, and they still want to like put a adaptic and then a wound vac over it. Still,
Well-
for fluid management, would the graft survive?
you don't want the graft to survive. I mean, a skin graft? they don't
No,
survive
the
on
fat graft.
A fat graft? No, the fat graft you don't want to survive.
Yeah.
You're looking for something totally different from it. You're looking for the wound healing stimulus from growth factors.
Right.
And those things will be the things that allow the skin edges to revascularize and begin to flow.
Sure.
So you don't think of it as a graft because it's a topical dressing. Yes, sir.
On the depressive wound healing
Yes.
patient, how many sessions and how far apart was the patient treated?
Between four sessions at 4 to 6 usually, but you remember that you're spreading that over weeks of periods. Instead of doing dressing changes every other day, you're doing dressing changes once a week or once every 5 or 6 days.
I'm talking about the injections.
The injection, same thing. You're going to only do that treatment as according to the wound response. And what you can't tell people, and what people want to know at the meeting, is they want to know, well, how many times do I have to do it? Well, it's specific to the wound you're dealing with and the vascular supply that's already around it. Oh, what exactly am I injecting?
For that healed specific
On the
patient.
heel, around the margins? Now, that's micronized, as you call it, partially emulsified is good enough. Because I'm going to put it in there and I'm going to pre-tunnel to create a space and then fill that space with this fluid. I don't attempt to overfill it. That's the point I was trying to make. You probably make 2 passes in the margins and then the topical wound will do the magic on the surface and the granulation stimulation. And the ones along the margin will do vascularization of the devoided tissue cells that are ischemic at the wound edge. And it's the wound edge is where the magic is. So that's where you pay attention to that.
Right, so each session, the fat had to be harvested and processed in this system.
How long did it take? Did you do it? Yeah. On most of these wounds, the volume's so small
Yeah.
that it takes as much time to do the PRP. So we draw the blood first while I'm aspirating. It's ready to go with this go the thing. It probably takes in a wound like that to do, other than being gentle with the patients, it probably takes you half an hour or 20 minutes. Half an hour, that's about it.
Very impressive result.
It blows me away. It impresses me every time. Yes, sir?
Dr. Hudson, thank you.
Oh, no.
I know, I always bother you.
No, you don't bother.
If I'm harvesting a lot more I have a canister of fat, right? So I'm also doing liposculpting. So I have more fat than for transfer to the buttocks, of course, but I want to go to the face as well. So I micronize what part of it is the best, because it's in the canister. I don't know which is from, say, the lateral flanks that you may like better.
I would say to you that it's probably not relevant. It's not a measurement you have to worry about, and if you'll use a micro cannula, a small one, so you're creating, the smaller the cannula is going to create, the smaller the aggregate. Okay, so if I'm going to use that in the face, then I will just go and be sure I use, I like a 1.6, which is not made anymore, but the 2.1, you're going to get small particles that will work great for facial grafting. You don't have to mess with anything after that. Certain areas in the face, like the eyelids, like we're talking about, lower lids, you've got to go under the muscle. And for that purpose, you can really, I think, nanofat works better there, or age spots, or areas where you don't have a solid fatty layer. I mean, if it is, it's there, but it's thin. So some of the people that kind of include that with what they call the vampire face, that's where they've got the injectable PRP going in. And in those particular cases, using a small needle, small injector, single port, you can just cover all the surface areas of the face pretty good if you can get the patient comfortable. I mean, as long as you sedate them slightly or something.
No.
Comfortable. And you don't have to go through a bunch of monkey motions. If your particle size is small as the 2.1 millimeter maximum will allow, you're going to find that will give you enough surface, and that soft tissue will flatten and it will accommodate and get the surface changes you want.
Sounds good. So maybe two canisters, one for the large fat, for large area transfers, say breast or buttocks, and change the canister for small caliber 1.2 or 2.1, you're saying?
Okay.
How percent?
The answer, from my opinion, is you'd probably use a 3 millimeter or maybe a 3.7 to do the hardest for the debulking, and you're going to use that for your buttock transfer, and then you're going to use the micro cannula for the face. So you have different recipients, but you're going to be in a 20 cc syringe for the face. That's probably all you're going to need, because remember, you've got 10% of the volume that you're going to transfer is coming from platelets, 90% coming from the graft.
And comment about the G force required for the SVF, tissue SVF. I want to spin down to get the pellet, and I want to reintroduce it into my graft for the facial transfer.
Now you've called it sort of oranges and apples and trying to put them in the same bag. Cellular SVF is going to have to be digested, and for that.
No, I want tissue SVF. I'm sorry.
Please state your question.
Sorry. So I have this infernatin that usually I discard that, right? So I want to spin it down to get the pellet so I can get that into my small micronized fat for face.
Well, you don't need to do that. If you're going to take the cannulas, don't use the 3 millimeter cannulas or 3.7. Don't use that particle size. Don't mix them with a micro cannula. Just use the micro cannula first, harvest your small stuff, and come back in and do your contour in a bigger cannula. That way you've got all the tissue SVF for the buttocks from the bigger cannula, but you already set aside enough for small fat particles. You don't have to micronize anything. You're making the small particle aggregates by the size of the cannula that you're putting in there. Hydraulically, pressure will determine that. So you don't get big volumes and big aggregates out of a 2.1 millimeter cannula. You can't do it. But you can get big volume out of a bigger cannula. I unfortunately go back in the days of liposuction when we used 10 millimeter cannulas.